Okay, everybody ready? We'll get started. Hello, everyone. Again, thanks everyone for coming again. Today is the end of rotation, I imagine. Yeah. On such a day where you should be celebrating, but instead we're celebrating with YESPA. So today we're doing paper 3. So we're not actually doing cheeky questions, around out of time. So paper 3, part 1, which is just the GP side of it. Now this one does have faculty release answers, but with these things, I always think that knowledge is always good. And going through these questions, even though the answers are there and they're from the faculty, so that they're accurate, I still feel like there's a lot of benefit to get from going through these questions and going through the reasonings behind why particular things are the answer, and then revising each of these option sets. Now, that's my intention, so I hope in some way it helps out. So we'll get started. So let me just put the sound down a little bit. Okay, now starting off, so we have a 54-year-old woman. So 54 woman, she's presenting with moderate hypertension despite lifestyle modification, and she has troublesome Raynaud's disease. Okay, so what medication should she be put on? Now, last week we were reading from the heart failure guidelines that somebody with peripheral vascular disease can be started on which medication? So from the heart failure guidelines, they can be started on any first-line medication. So any first line. But remember, in that question that we did, there were several things in the question that led us to what the correct answer was. So for example, there was COPD, the patient also had angina, which allowed us to pick CCBs as the best answer. So specifically for something like Raynaud's, CCB is correct as the first line. Well, which one is it, F or G? G. F or G? F. Okay. Can you tell us why, Sai? Yes, peripheral, so it's not centrally acting. Okay. So with Raynaud's, the problem is that somebody has vasospasm, and that's usually in response to something like cold exposure just cold exposure or stress, and that presents with your episodic blanching, your cyanosis, and erythema of the digits, which you can see here. So what we usually call the difference in color is what that you can see in Raynaud's. Now, usually it can either be a primary condition or it can be secondary to something else. So what is something that Raynaud's is classically secondary to? Scleroderma. Okay. Now, what is one class of medications that we don't want to use in Raynaud's disease? So CCB is a first line because of the vasodilatory effect. That's true. But if we use the beta blockers in somebody with Raynaud's, it can actually worsen their symptoms. So we definitely don't want to use beta blockers. So the answer to this question is CCB is the peripherally acting one. Second line medications for anybody who can't use the calcium channel blocker for whatever reason. So you can use things like GTN. So you can use GTN, you can use alpha-2 receptor antagonists. You can use PDE5 antagonists. You can use SSRIs. So there's a range of other medications that you can use instead. Next question. So we have an obese 54-year-old man who has a past history of angioedema. He has newly diagnosed type 2 diabetes. He has mixed hyperlipidemia. His BP is persistently high, and he has some evidence of renal damage. So what medication would you start in this gentleman? Okay, so I heard ACE, I heard ARB. So why would what is there any other medications we might consider? CCB. Anything else? Okay, so how then do we arrive at what the correct answer is? That's a very good answer. Okay, so that's correct. So ACE inhibitors are preferred for diabetes, okay? Specifically, it's preferred for diabetic nephropathy. The reason for that is because there was a very large trial which showed that it actually decreased the progression of diabetic nephropathy, but it didn't necessarily prevent it or reduce the severity of its effects. It just reduced the rate of progression. So let's talk about diabetic nephropathy first of all, because remember, this is a revision presentation rather than just knowing what the answer is. I hope you guys don't mind. So diabetic nephropathy is actually a clinical syndrome, okay? So it's a syndrome. It's not just a symptom or a diagnosis within itself. So it has three particular things inside of it, okay? So the first one is you have persistent albuminuria. So you have increased albumin in your urine. Okay, so usually more than 300 milligrams a day. Okay, and that has to be confirmed on at least two occasions. So two occasions that are at least 3 to 6 months apart. So you can imagine, therefore, to diagnose someone with diabetic nephropathy, it should take at least 6 months. Then the second one is a progressive decline in your eGFR. So I'll just put that as that. And then the last one is that you have increased blood pressure. So you have hypertension. So that's why a patient with diabetic nephropathy often has hypertension at the same time. And that's due to the increased arterial changes. So why do people get diabetic nephropathy? So usually thickening of the basement membrane, some sort of expansion of the mesangium, and just general destruction from increased pressure effects you get from the glycosylated destruction of that parenchyma in the kidneys. So ACE inhibition has been shown to delay the development of diabetic nephropathy. So ACE inhibitors, is that the answer? No, why not? Yes. So one of the relative contraindications with somebody with ACE inhibitors is angioedema. So this little box is directly from AMH, so Australian Medications Handbook, and it says here, ACE inhibitors increase the risk of further episodes of angioedema in people with hereditary, idiopathic, or ACE inhibitor-induced angioedema. So we don't necessarily know what type of angioedema he has had, but in his case, it'd be better, we would be more safe if we went with a instead, an ARB instead. So that one, angiotensin receptor, yeah, that one. So that's what you need to know about that. So another thing is that very similarly, somebody who's from Afro-Caribbean origin, they have an increased risk of having angioedema with ACE inhibitors. So that's another subgroup of patients where we might consider a different class of medications than ACE inhibitors. Okay, so that's the reason ARB is the better answer than the ACE. It's not a contraindication to my knowledge.
They have hypertension and dyslipidemia and that kind of stuff. CCB.
I mean, the important thing here, right, is that sure he has hyperlipidemia, but ACE inhibition has been shown to decrease the progression of the diabetic nephropathy, which is the most important thing, because the diabetic nephropathy is what's going to increase mortality. Not saying that hypercholesterolemia won't do that. Okay, next question. So this is a question where, how do you find the answer? Guidelines. So a 21-year-old presents to your GP with episodic palpitations and breathlessness. He notices his symptoms occur after alcohol ingestion. So the question is asking us, what is the most relevant or most appropriate investigation to do next? So what would we do next for this patient? What do you guys think?
He needs an ECG, but it doesn't happen every time, so I put event monitor.
Okay, anybody else? Okay, so event monitors, Holter monitors, these come under, I guess, the broadcast telemetry. Do we understand what the difference between the Holter monitor and the event monitor is? Okay, so we'll talk about it. Let's talk about it. Okay, so this is actually from a study, actually. I think this is from the American Cardiology Guidelines, so not necessarily guidelines you should rely on, but there's more relevant information soon. So what it tells us is, first of all, we have to think about, okay, alcohol and palpitations, relatively common presentation. There's many things that could cause that. So what are common things that could happen in this age group? Atrial flutter, you could have ectopics, it could be some kind of SVT. So there's many different things that it could be. So we have a clinical history of palpitations, and the next thing we need to do is an ECG. Now, the reason the ECG is important is because it's a simple test, it's a very accessible test, and it gives you, at the very least, a baseline. And that's important to know, is that for you to identify any kind of pathology, you need something to compare to, right? For example, I could look at your kidney function, or I could look at your FBE, and it could be markedly abnormal compared to what I expect to be normal. But I don't know if that's normal for that patient itself. So that's why we need a baseline to compare to, and that's why an ECG will give us that in the first place. So ECG is very important. Then the next one, if ECG recognizes that there's some sort of pre-excitation here, then we can go on to do different kinds of things, and we can look at what the potential diagnosis might be. So that's less important here, but AVRT is a common diagnosis that can give us this kind of presentation. Now, the other thing is sinus tachycardia. So what can cause sinus tachycardia? Alcohol. So there's many different things that could be causing these patient's symptoms. Now, to try and find out what the answer to this question is looking at RACGP. So this is not a guideline in itself, but this is from the Australian Family Physician articles, which I've actually found often a lot of the answers come from. Okay, so ambulatory ECG monitoring. So what do we need to do? So first of all, indications for using it. Palpitations of unclear cause despite clinical history and ECG, because ECG is very important, again, the baseline. Syncope or pre-syncope, where an arrhythmia is suspected as the underlying cause, which we don't have in this case because he has no evidence of syncope. Okay, so again, this tells us a baseline ECG should be performed. Now, the reason I've included this image here is because he gave me palpitations. So what this man is wearing at the moment is something called a Holter monitor. So he's got a Holter monitor on, which is something that you can go around with. And it monitors your ECG for many hours, so about 1 to 2 days. It monitors your whole rhythm. So then somebody has to go back and then look at it. And I believe they can press a button that tells you when they feel like they had an event. So compare that to an event monitor, which is this little thing here. So an event monitor is something that you can use for 1.5 years. Okay, so it's something that has a battery that lasts 1.5 years, and it doesn't record for the whole time period. But when you press the button, it saves that. So actually, sorry, that's not correct. So it records for the whole time, but when you press the button, it only saves that information it's been recording for that little period of time. So you could argue that either of these could be reasonable in this patient. However, there's currently no indication for it. He hasn't got syncope, and we haven't done an ECG, and he's only having these palpitation episodes after a chronological event, which is the alcohol ingestion. So there's nothing particularly concerning at the moment. Okay. All right. Is that okay? So ECG's answer to that question.
So would you make it drink alcohol in the ECG or?
I'm not sure how ethical that is, but I don't know, to be honest. I'm not sure. Again, and like I said, just reiterating that fact, ECG is important for baseline as well. Okay. So next question, we have a 52-year-old. He's diabetic, presents with dull central chest pain, breathlessness, and pallor to your GP, to you as the GP on duty for the emergency department in your rural town, which is very common. So he has a low BP. So what would we call a BP like that? Shock. Okay, so be very reasonable in a picture like this to call this shock. So in this case, given his symptomatic chest pain, we might classify this as what type of shock? Cardiogenic, potentially. Okay, initial ECG is unremarkable, so we can't prove it. So given that the ECG has already been done and it doesn't show us anything, what's next most important to do? A troponin. You could be shocked if any of your vitals are deranged. So given that he has hypertension, you can't necessarily rule that out. So it's just something to think about. All right, so with chest pain, any kind of chest pain, ECG is always first. So Monash guidelines, I don't think I have it. Monash guidelines say you have to do an ECG and it needs to be interpreted by a senior clinician within 10 minutes of presenting to the emergency department. And troponin is, I can't remember what the troponin guidelines are.
Would you think the PE for that?
I mean, the thing is that you always want to rule out red flags, so that's correct. So you always want to rule out red flags, and this patient will probably also get a chest X-ray. Okay, but you'd also wait for his troponins to come back. But I'm not sure what you might do in regards to a PE.
Would you do a D-dimer?
Maybe, maybe. His well score is definitely elevated. Okay, so he's a smoker. His age, breathlessness, chest pain. Okay, so just some quick revision before we go on to the next question set, and it's about venous thromboembolism in pregnancy and what we need to do. It's important to know the management. So this is directly from the Ranscott guidelines, which you can see down here. So conservative management, minimize immobilization after childbirth and after a C-section. Okay, so there's an increased risk of having a VT after a C-section itself because it's a surgical procedure. And for somebody who can't have pharmacological thromboprophylaxis, you need to do mechanical prophylaxis. So what would be a contraindication in the gynecological obstetric setting, so the ONG setting, to having pharmacological DVT prophylaxis? So in general, what is a prophylaxis? What is a contraindication for DVT prophylaxis? Bleeding, right? Anything that increases bleeding. What is a condition in ONG that increases, that is as a result of bleeding? Sure. What else more commonly? What is a common obstetric complication? That PPH, okay? So primary PPH with more than 1 liter of blood loss is a direct contraindication to using pharmacological prophylaxis. So imagine if that came up in your OSCE. So in that case, you couldn't give them something like Clexane, and instead you need to give them something like TED, so pneumocompression of the cuffs, which you use inside of the surgery itself, and you do outside on the ward as well, okay? So that's what point 3 is referring to. For anyone else who does not have a contraindication, we give them low molecular weight heparin for 5 to 7 days. And the reason for that, and the reason we don't use just normal heparin, so IV heparin, which is unfractionated heparin, is because there's less abnormal bleeding than you do get with Clexane. So contraindicated with women with PPH, which we just talked about. And again, the timing. So I've now become very concerned about knowing my timings because I got wrecked in my last year's ONG exam with the anti-D timings because I didn't know them, but I knew the doses. So now I know my timings. So you want to give it more than 4 hours after surgery. Yeah. So give it more than 4 hours after surgery, but as soon as possible in that time period. Okay. Now, so 5 to 7 days is your normal answer. And then in some women who are high risk, I still couldn't figure out what high risk meant. But for women who are high risk, you extend that to 6 weeks with either low molecular weight heparin or an adjusted dose of warfarin. Okay.
And hers would just be like previous actual like thrombo
True.
conditions and like obesity. So I think there are a few.
But that's definitely a very good one. That's a huge one. Okay. So what else did I want to talk about? Okay. So before we go on, should I go on? Okay. So that's just some information that you should know about. So then to answer the question itself. So what we have a 36-year-old woman who presents to the GP at 32 weeks with breathlessness and lateral chest pain. She has some non-tender peripheral edema, heart rate is 85, and there's no other abnormality on physical examination or on the ECG. So what does she have? She's a bit short of breath. She has chest pain. She has some peripheral edema, and her heart rate is mildly elevated. So this picture paints what? A PE, okay, likely, right. So in that case, what would you choose as the answer? So it's asking us the most appropriate and relevant investigation. Okay, so we have VQ scan. What else could it be? X-ray. Where is that? Where is X-ray? Okay, CTPA. What else? D-dimer. Okay, so we'll leave that there for the moment. Okay, and what you need to know is that the faculty answer to this question is D-dimer. Now, I personally disagree with this. Okay, now there's a few reasons for that. One is that D-dimer becomes physiologically elevated in most patients after the first trimester. So the normal values for each trimester have not yet been validated. So that means that looking at the first trimester is this much in the pregnant lady and this much in the normal person. That hasn't been done yet. So that means that somebody who's coming with an elevated D-dimer and the pregnant, we can't know if that's a realistic increase or that's a physiological increase due to pregnancy. Okay, so D-dimer is not generally used to screen pregnant women for suspected PE, particularly during the second and third trimester when they might be markedly elevated. So if a PE is suspected in the woman, a chest radiograph should be performed, so you're correct. And that is to, 1, rule out other causes of the symptoms, such as pneumonia, and number 2, to determine if a VQ or a CTPA should be performed as a diagnostic test. Okay, so if the chest radiograph is clear, VQ scan is good because you give the same radiation dose to the fetus, but it has a lower radiation dose to the breast compared to CTPA, which is why VQ is preferred in pregnancy. So all of that information and these following slides are all from the RAND-CR guidelines. So actually, it's not a guideline. RAND-CR stands for the College of Radiologists, and this was actually just an education module for appropriate imaging referrals in suspected PE, which was released in 2015, which is probably after this exam paper is released. I'm theorizing here. Okay, so the first question asks us, and this is from that RAND-CR paper, so which of the following are true of suspected PE in pregnant women? So the prevalence in most clinical series is less than 10%. Is that correct or not? Yes or no? That is correct. Okay, so the absolute incidence is somewhere. So the absolute incidence is about 0.13% of all pregnancies from a Cochrane review, but the risk of having a PE in pregnancy is somewhere like tenfold higher than the normal general population. Okay, so the next one, a VQ scan confers a lower radiation dose to the breast than does CT. Is that correct? Yes, that's true. D-dimer is useful for screening in women at low risk in PE in order to avoid the need for imaging. Is that correct? So not according to this, so the College of Radiologists paper. Lower limb compression ultrasound shows evidence of DVT in about 35% of pregnant women with PE. So it's actually very low, somewhere more around like the 5% rather than 35%. The radiation dose conferred to the fetus is substantially lower for CTPA than for VQ. They're about the same. So the answer to this question is the first two. So like we were talking about, D-dimer is physiologically elevated, which is why I'm not sure why that's the answer to the question. So let's go on to the next learning point from this paper. So a 35-year-old woman, 13 weeks pregnant, with a suspected PE, has a normal chest X-ray. What is the most appropriate investigation to exclude or confirm PE? What do we say it is? VQ scan. Okay, so the answer is a VQ scan. Okay, I wish I hid that. But the Wells score, important to know, it can't be used in pregnancy. That's important to know. That's one of the exclusion criteria for using Wells score. And the reason I bring that up is because other students in the past have used that as evidence for citing why D-dimer was the answer, but it can't be the answer because you can't use it in pregnancy. So talking about pulmonary embolism very, very quickly, what symptoms do we have? Shortness of breath, chest pain, which is pleuritic. So that's very important to note, pleuritic chest pain. They might have some hemoptysis. They might have a DVT, and they have these changes in the OPS, so increased respiratory rate, increased heart rate, and decreased O2 saturations. So what are the risk factors? Now, this is also really important. So imagine you're in the OSCE and they ask you, what are the major risk factors for this patient for having a DVT? And the reason I put this in is because the major risk factor is not prolonged immobilization on the airplane. It's like prolonged immobilization after many weeks, potentially after a surgery. So thrombophilia, surgery, malignancy, some other things that I can't remember, acute on chronic illness, immobilization, that's for a very long time, and some hormonal factors and BMI. So these are the major risk factors for having a PE. So what comes next? So these are what a Wells score can be used for. Okay. So symptoms of DVT gives you 3 points, pulmonary embolism most likely, etc., etc. So we don't have that. We have potentially that. Previous DVT, we don't have that. We don't have that. We don't have that. Okay. Now these things on the left-hand side of your screen are reasons why we can't use the Wells score. So these are exclusion criteria for the Wells score. So somebody who is pregnant, somebody who's been on anticoagulation for more than 3 days already, we can't use the Wells score. If you think that they've had an upper limb DVT, it hasn't been validated for those kinds of patients, and they've been asymptomatic for more than 3 days before coming into hospital. Okay, but otherwise, in all other settings, the Wells score is very good as a clinical diagnostic tool. Clinical diagnostic tool. Okay. So if you have a score greater than, I think that should be greater than, a score equal to or less than 4 makes it less likely, so it makes the pretest probability that you've had a PE very low. In which case, you then go on to do something called the PERC score, which we've talked about, which is the pulmonary embolism rule-out criteria, which has different things inside of it. Okay, so this is just an example of what you might see in a, these don't work, do they? Because it's not Google Slides. Anyway, this is going to show you a really, really cool video of what they do in the CTPA, so inserting the contrast and then looking at how it looks in the lungs. And then this video is going to be even more cool because it was going to be a bilateral PE. So I wish I could have shown you that. Okay, so just general PE management. Okay, so severely compromised patient refers to somebody who has hemodynamic compromise. So somebody who has a systolic blood pressure less than 90, bradycardia less than 40. So if you look at your observation charts on the ward, you know how it has different colors. So those refer to somebody who's hemodynamically compromised. Otherwise, low molecular weight heparin, and then in the long term, you can do warfarin or rivaroxaban.
It's not like first line,
It might be.
So you can use like the bigger channel with warfarin first, and then warfarin just go up to first line.
I'm not too sure. I'm not sure. I'm not 100% sure. I'm sorry, Roland. Okay, so if I was to answer that question, I would personally put VQ, not D-dimer.
Maybe even 6 now.
Or even
the more you look at this question, the more like wrong it seems.
yeah.
Like, the more-
If
the
chest
more-
if
the
chest
more
X-ray was
research-
there, I would have chosen chest X-ray.
Put up a diagram on Rose here.
Okay, very good. All right, is that okay? Very good. Okay, so we have a 63-year-old man.
Another thing to mention is that just because the answer was right in a previous exam doesn't mean it's
Yeah.
right in the exam.
Yeah, a lot of people learned that the hard way last year. So 63-year-old man, he's begun treatment for moderate hypertension in the past 4 weeks, presents with a 5-day history of dry cough. His BP is now 148/92. So what should we do? What kind of investigation do we need to order for this patient? So from no investigation, okay. Now the reason for that is somebody with moderate hypertension who's been in the past 4 weeks, right? He's only been treated for the past 4 weeks. From the guidelines, we can assume that all patients with hypertension are always initially treated with an ACE inhibitor unless contraindicated. So it's very logical, or it's okay for us to assume that this patient is on an ACE inhibitor at the moment. And the most common side effect of an ACE inhibitor is the dry cough. So you might argue that other things might be relevant, for example, maybe doing a UEC, but especially in this short time setting, in the 4 weeks, you're unlikely to see any kind of renal dysfunction with something like an ACE inhibitor, which is why no investigation is still the best. Okay, and you probably change his medication as well. So just talking about why it actually causes dry cough, I'm sure many of us remember this. It might be helpful for the VIA, who knows? If I get you that 1 mark, that'd be amazing. So ACE inhibitors, ACE, so angiotensin converting enzyme, what does it do normally? Converts angiotensin 2 to angiotensin 1. So where does it do that? The lungs, it's the lungs, yeah? I can't remember. It does that in the lungs, okay? And the other thing is that it converts bradykinin to these inactive metabolites. So bradykinin is something that's also implicated in asthma. So bradykinin, when it's elevated, it activates our C fibers. So if we remember, our C fibers are our slow fibers because they don't have myelin around them, and those are implicated in what sensation? In pain, okay? So you remember your C fibers are for pain. So similarly, C fibers in this case are also for causing a cough. So that's why bradykinin elevated with an ACE inhibitor causes a cough. Okay. Now we have a 46-year-old man. He's just flown back from China. He has a 10-day history of decreased hearing of the right ear. He has a blocked ear. He has tinnitus, but no ear pain or discharge. His right ear revealed injection of the tympanic membrane and along the handle of the malleus. What do you think he has? Okay, so I'm not going to explain that right now because we're going to have a few slides, much like we had last week, talking about most of these options briefly. Okay, briefly this time. Okay, so the acoustic neuroma, what is it? Primary. So remember, we talked about this. Primary and secondary, what's the difference? Primary is the initial disease process. That is not secondary to any other kind of disease process. Okay, so primary intracranial tumor of Schwann cells. So Schwann cells are the things that produce myelin that go around our nerve cells, usually of cranial nerve 8, that causes an asymmetrical, high-frequency sensory neural hearing loss due to damage to the cochlea. So symptoms, tinnitus, vestibular dysfunction, so balance disorders, and it's due to a spontaneous mutation in your tumor suppressor genes. Okay, so where is the pathology on this MRI brain? So left or right side?
Down.
On the image. Okay, so here, okay. So what we see is this acoustic neuroma, you can see I think that's the temporal bone there. So it's in that general location, and it's indenting onto the brainstem on the left side of the patient is asymmetrical. So it's quite big. Now what we see in this image is the high frequency hearing loss that you can get with somebody who has an acoustic neuroma. So in this case, what do we see here? Can anyone interpret this image? What does it paint a picture of? You paint a picture of sensory neural hearing loss. So how would that differ from conductive hearing loss? I was hoping you could tell me definitively because I didn't know. Okay, so look it up at home. Okay. So sorry, that is supposed to be a otitis externa. So inflammation or infection of the external auditory canal. So different types of otomycosis is with fungal species, so it can be candidas among other things. Chronic otitis media is defined as more than 6 weeks. And on the examination, what are you going to see? Pain and palpation of the tragus or traction to the pinna. So on this image, what is the tragus? So I'm going to move my cursor up. Tell me when to stop. Tell me where to stop at the tragus. Where? Very good. What is the pinna? Yeah, good. This part. So anywhere there is going to cause pain. Okay. Now, acute otitis media. So as you can tell, there's many different classifications and types of acute otitis media. And I think this is very important to understand what the different types are. Okay. So acute otitis media by itself. Otalgia, so your ear hurts. You have a bulging tympanic membrane and erythema, so it looks very red. You might have some perforation. You might have some discharge. It's usually due to a virus. And very often, secondary to eustachian tube dysfunction. So some kind of upper respiratory tract infection is going to block off that tube, is going to prevent drainage of that ear, and stagnant fluid can become infected, causing an acute otitis media. And bacterial causes are still possible, so strep marxella are some of the bacterial pathogens that are implicated. So that's simple AOM. So one of the most important complications with AOM is the air cells break down inside of the mastoid bone. Okay, and you have pus that goes into there, and then it goes into your bone and soft tissues. Very important complication. That's why you need to urgently refer to ENT so that they can do an incision and drainage and grommet, and they can review it further. Okay, then the next one. So AOM, so chronic otitis media with effusion, is also called glue ear. Okay, so chronic otitis media with infusion. So a middle ear infusion, which just means fluid behind the tympanic membrane, that has lasted more than a few weeks, typically more than 6 weeks. Okay. And the tympanic membrane will look opaque and thick. Okay? All right, so if you have hearing loss and there's no other complications, you can just evaluate it clinically. So how does it differ from just acute otitis media? Is that the tympanic membrane is retracted, it's not bulging, because it's not a fluid substance, it's more of a suppurative substance. And the lateral process is prominent that you can't see in AOM. Okay, so then adhesive, so chronic adhesive otitis media, tympanic membrane is thin and it adheres to the ossicles and causes erosion, which can increase your chance of having a perforation. Suppurative otitis media, so look at this and compare it to how it differs from COME. So suppurative otitis media, so you just have fluid behind the ear with no symptoms of acute inflammation. So for some reason you've developed that fluid, but you don't yet have inflammation, so it's not like a bacterial or viral process. Okay, so it might be some residual effusion after having acute otitis media, and it usually settles by itself. If that lasts a really long time, so if you have that fluid behind the ear for a really long time, it becomes chronic otitis media with infusion or glue ear. So the natural progression is this. So AOM becomes SOM, and then SOM becomes COME. So that's the natural progression if somebody's having those kind of symptoms. So then chronic suppurative, deafness and discharge, this actually is into different persistent inflammation, and you have some pus, you have some perforation, and you have some hearing loss. And the perforation takes a lot of time to heal, and you will likely need some antibiotics. So cholesteatoma, we know, is a non-neoplastic accumulation of keratinizing squamous epithelium, so stratified squamous epithelium on your membrane. It's a version of CSOM, okay? So a CSOM, and it can erode into other structures, okay? Now, bullous meningitis is a viral cause that presents with blisters in the ear, but it's managed very much like otitis media. So just with that in mind, so AOM can become SOM, which can then become COME, which is also called glue ear, okay? All right, so keep that in mind. So then we can look at these images. So the first image that we see is one we see a very bulging tympanic membrane with a lot of erythema in the surrounding tissues and the surrounding area. So a red bulging membrane is diagnosed, is more likely A. So what's the diagnosis? AOM. Okay, so this is acute otitis media. So what is the next image? So the next image, you see these blisters. So you see these blisters, especially on the sides of the tympanic membrane. So that is bullous meningitis. So that's bullous meningitis, so BM. So in this one, you see breakdown of tissue. You can't see any identifiable tympanic membrane in that location. You have these odd masses in this location that is actually squamous epithelium and keratin that is adjacent to the bone. You could also appreciate that there's likely some bony erosion happening there. So this is a cholesteatoma, that's correct. Okay, then cholesteatoma. Then the next one is, and what do you guys think this one is? So this is some kind of perforation. You can see here that there's no tympanic membrane located there. So that could be many different things. What do you think this last one is? So it's not, you can definitely see a coronal light there. You see a little bit of opacity there. Okay. So this could be CSOM, it could be glutea. This is a range of diagnoses that it could be. Okay.
So CSOM versus COM is defined by something.
Sorry.
Defined by parts, is it?
That's it's difficult to tell apart. Okay. So glutea specifically, all right, is unlikely to have any of the inflammatory symptoms that you'd see in any kind of acute otitis media. So it just have the potential hearing loss as well as deafness symptoms and such. For CSOM, you do have some inflammation. You might have some perforation. Actually, it would lead to perforation, and then you'd have the pus drainage.
Right, so COM, you don't have drainage.
So this actually would be more likely to be CSOM. What am I saying? So CSOM, and then this one is more likely to be glutea. Okay. So glutea is actually the most common cause of deafness in this age group due to the accumulation of fluid behind the ear. Okay. So then continuing on with these options. So eustachian tube dysfunction. So, oh my God, where did I put it? Okay, so eustachian tube dysfunction. So normally the closing of that tube protects the middle ear from unwanted pressure fluctuations. Okay, because it's the only connection between your middle ear and the outside world. So long-lasting dysfunction can cause chronic otitis media. It can cause otitis media externa. Sorry, that's supposed to be COME. So chronic otitis media with effusion and perforation. So that's often what's implicated in a big risk factor for somebody having some kind of ear pathology. So how does it differ from middle ear barotrauma? So barotrauma is an injury, okay, that's caused by a difference in pressure between the gas inside and in contact with outside the body. So in this case, the middle ear is contacting the outside of the body via our eustachian tube. So when, for example, we're in the plane, then we're going from different altitudes, the pressure is changing. And what can happen in that case is that you can have bubbles that are trapped and then that go to the ear and then cause your different symptoms. So this was another video, I wish it played, but what you would see is that, so it was a otoscopy, or I'm not sure if they call it otoscopy, but they put the camera into your ear. And what they noted is that when they got the patient to do the Valsalva maneuver, okay, so Valsalva maneuver is when you're doing this, you're increasing intrathoracic pressure and the such. What they noticed was that these little bubbles were floating through the middle ear, which was diagnostic of somebody having some kind of middle ear barotrauma. So what happens is that on an airplane, barotrauma to the ear can happen when the plane is descending for landing, okay? It could also happen when the scuba diver is descending. So differences in pressure. So that pressure change, it can create a vacuum in that middle ear. So it creates a vacuum in the middle ear that pulls the eardrum inwards, okay? Pulls the eardrum inwards, and that can cause panic and muffled sounds. So all of us have probably felt this when we're on an airplane. How we get this muffled hearing, and that's due to the vacuum that's created inside of our middle ear. And what you'll need to do is you'll need to do like this, or you'll need to yawn or do something like that to pop that ear to remove that vacuum. So what can happen is that in more severe cases of barotrauma, the middle ear can fill with clear fluid for some reason as the body tries to equalize that pressure on both sides of the eardrum, okay? So that fluid is drawn out of the blood vessels. So it's drawn out of the blood vessels into the middle ear, which is why we get fluid with somebody with a middle ear barotrauma, and which is why this patient, when they were doing the Valsalva maneuver, they were getting these little bubbles that they could see inside of the middle ear. So barotrauma is the answer to that previous question. Does that make sense? I didn't explain that clearly, but what? No, you wouldn't always, but that's something that they can see, and that's what they did see in that patient. I wish I could have shown you the video. So the reason I couldn't is because I went from Google Slides to PowerPoint. Okay, so perichondritis. Have you guys heard of this before? Okay, so what does peri mean? next to. And what does itis mean? Inflammation. What does chondral or chondra mean? Cartilage. So inflammation around the cartilage of the ear. Where is the cartilage located in that ear? In these locations, okay? So it's infection of the pinna, which is why it looks very similar to acute otitis externa. Okay, so it occurs more frequently in people that have some kind of underlying inflammatory disorder. So, for example, Wegener's, so granulomatosis with polyangiitis. So what happens is you have this pus accumulation between the cartilage and the connective tissue, which is called the perichondrium. And this abscess can sometimes compress the blood supply that results in vascular compromise and subsequent cauliflower ear. So the reason for that is because cartilage does not have a strong vascular supply. So anything that pinches it off can cause damage. And you guys might have seen like boxers and stuff that have these like cauliflower ears. So it's like really puffy ears, and that's due to having constant trauma to that area. Similar thing happens with Wegener's where you get a saddle nose. So that's also due to damage of that septum, our nasal septum, damage to the cartilage. That's because Wegener's is a vasculitis, and that can damage the blood supply to that cartilage, resulting in your saddle nose deformity. So a similar thing here and why it's related. So in terms of management, ETG wasn't loading for me. Actually, sorry, it wasn't on ETG. So the management, from what I could find, might be fluoroquinolone, but I'm not 100% sure. So you need to look it up. Otherwise, steroids, something like dexamethasone to decrease the inflammation, and in severe cases, referral to ENT to have an incision and drainage. Okay, so finally back to the question. So again, just making sure that we know each of the options in the question is why I went to that much trouble to go through each of those options.
So that slide with the 6 pictures that you had before, on the bottom left. Yeah, on the bottom left. What's that yellow thing?
You mean this here?
Yeah, yeah. That's what I thought. Yeah, is it? 'Cause I thought it might be consteatoma, but I'm not sure. I don't know what it actually looks like. I just thought it was like the picture they used for consteatoma.
Looks like it could be.
Might be. I'm not too sure.
Do a reverse image search.
Okay, next question. So we have Jack. He's 24. He's an avid surfer. What does he have?
Yeah, I think I've had the exact same picture.
Acute otitis externa. So, classical question. All right. So next question, we have Annie. She's 6 years old. Her mother says that Annie seems to sit very close to the TV when watching programs and does not seem to hear her call out to her. So what does she have? Well, what is this symptom? Deafness. Okay, so she has some deafness. That's what is trying to relate to us. She has a history of recurrent upper respiratory tract infections. Why is that important? Well, particularly, so viral tract infection can give you eustachian tube dysfunction. I remember one of the biggest risk factors for getting any kind of otitis media or something of that nature is having eustachian tube dysfunction. So that's why upper respiratory tract infections is important, as well as the fact that these are often viral in nature, the ones that you get. So tympanometry shows a decrease in the mobility, and audiometry shows bilateral hearing loss. So it's affecting both sides. The other thing is that we don't have a time frame, so we don't know if it's more than 3 months. If it was more than 3 months, we could diagnose it as a chronic otitis media with infusion or a glue ear. In this setting, we also don't have any inflammatory symptoms. So what is the best answer? Anyone? So do you think it's acoustic neuroma? No. Externa? No pain. Otitis media? No otalgia again. Eustachian tube dysfunction? Wouldn't present with deafness. Meniere's disease? No vertigo. Middle ear barotrauma? We've already discussed. Perforated tympanic membrane? No, they didn't say it's perforated. No discharge. It shows a decrease in mobility. If she had a perforated membrane, there'd be no mobility at all, right? Okay. Perichondritis? No, and secretory otitis media. So that's the answer. So if we go back to our table that told us about the different types. So what it tells us about where was it? There you go. So what it tells us about secretory. So where can we go? So we'll just say suppurative, right? So fluid without symptoms of acute inflammation, which it didn't have. It might be a residual effusion, and if it's more than 3 months, then we call it a glue ear. So we didn't have a time frame in that question, but we did have evidence of some kind of fluid buildup behind the ear because there was decreased mobility, and we had associated deafness, which is why suppurative otitis media is the best answer. So I mean that the vacuum effect that you get is, like we said, because of when you're in a plane and you can't equalize the pressure. Whereas the eustachian tube dysfunction just it decreases your ability to remove the fluid from your ear. So just eustachian tube dysfunction itself is unlikely to cause you to have any kind of problems with your tympanic membrane.
I'm pretty sure one of the tympanic glands is like type C or something. It's classically stage it's just like naturally.
I don't know any. Please look it up and tell us.
I think if it's like non-painful, we can put secretory generally, because the other ones are like.
I'm sorry, I can never answer your question more. Okay. All right, we have Alice. She's 50 years old. She has a history of nausea, vomiting, and vertigo, decrease in hearing, tinnitus since the morning. The vertigo is so intense that she's unable to get up. She had an attack 6 months ago. Many years, okay? So I'm not going to go through vertigo because we've gone through it before in other exams. So, but just remember your time frame, so how long each type of vertigo lasts for, different symptoms and different management, okay? All right. So the next one. So we have a 42-year-old patient, presents to the ED with diffuse worsening abdo pain, presents for the past 6 hours. He has had indigestion for the last 6 weeks, looks unwell, so has, indigestion, pale, clammy to the touch, and extreme discomfort. Examination of the abdomen is limited because of pain and board-like rigidity on palpation.
Oh, sorry, just back to Roland's previous question about conducting this instrument. It's like, doesn't it have bone conducting, air conduction? So you can just look at.
Yeah. Yeah, true. So on that tympanogram that we were looking at,
Not tympanic, it's like
audiogram, sorry, on the audiogram that we were looking at, yeah, so different symbols mean conduction and sensory neural, I believe. Okay, so this question we have, so what do you think? This is a classical picture of peritonitis, okay? So the fact that she has board-like rigidity, okay, that she has abdominal pain, and that she's pale and clammy with, so sort of shock type symptoms and extreme discomfort, paint a picture of peritonitis. Now this is likely secondary to a peptic ulcer because she's had this indigestion for the last 6 weeks. So in medicine, what do we call indigestion? Dyspepsia, okay? So up to 80% of people with a peptic ulcer complain of having dyspepsia. Now this question asks us to select one option that most closely matches the clinical scenario. Now, what's the importance here is that we don't know for certain if she's had a peptic ulcer. What we do know for certain is that the most likely diagnosis in this case is the fact that she's had a perforation resulting in peritonitis, because that would give you this board-like rigidity of the abdomen and this diffuse abdominal pain. Okay, next question. We have a 72-year-old woman. She was put on amitriptyline several weeks ago for trigeminal neuralgia. She presents with abdo pains that come intermittently in waves. She's vomited foul-smelling brown liquid several times in the past 24 hours. The abdomen is resonant to percussion. What does this paint a picture of? Bowel obstruction, okay? So some people might ask, is that, where is it? So some people might ask, is that related to amitriptyline? Now, there's some I think it's very rarely, very, very rarely associated with amitriptyline. I don't actually think the question is trying to tell you that a TCA causes intestinal obstruction, but what you can think about is that, for example, amitriptyline being a TCA has several anticholinergic side effects, okay? So being an anticholinergic and your digestive system relying on your parasympathetic innervation and acetylcholine and such, that in some cases you could theorize that it could cause an obstruction that way, but that's just my hypothesis and I don't know. But the symptoms and the clinical picture in itself tell us that this is bowel obstruction rather than anything else. Okay. So then the next question, we have a semi-conscious 24-year-old student found by his friends at home. No medical history. He's had chicken pox 10 days earlier, which is very important. He has been complaining since that time of this vague central abdo pain. He's been thirsty. He's been frequency. He's had nocturia, no dysuria, and his breath smells sweet. So what he's got polyuria. He's got polydipsia. His breath smells sweet is called ketotic breath. So ketotic breath, okay? And this is in the setting of a recent viral infection. So remember what I told you, chronic conditions do not become acute unless there's some kind of precipitant. So in this case, the precipitant is the fact that he's had a viral illness, which is chickenpox, and he's presenting in DKA, okay? So DKA can present in several ways, okay? One of the ways it can present is as the first presentation in the, I mean, no, it says child here, but as the first presentation in anybody with previously undiagnosed diabetes. So it's very common that this can occur, that you can be diagnosed with type 1 diabetes as a first presentation DKA. Otherwise, precipitated by illness, which is what has happened in his case, or the fact that you forgot to take your insulin, or you forgot to take your insulin. Okay? So how do we diagnose it? They need to have some kind of hypoglycemia. 11 is actually pretty small of a cutoff, so it's a bit low, but you need to have hypoglycemia of some sort. You need to have ketosis, so the evidence that we have is that the sweet swelling breath, and then you need to have some metabolic acidosis as a secondary effect to all of that. So how does DKA, okay, which is an absolute insulin deficiency, differ from so hyperosmolar, hypoglycemic state? I was thinking, what's the last thing? How does it differ from that? Because both of them present very similarly. There's no ketones, okay? Why is there no ketones? Can you explain to us?
I don't actually don't know.
I don't know, just it's all like
Okay, so with somebody that has type 1, okay, they're unable to produce any insulin at all, which is why they need insulin to put all of that glucose back into their cells to use it in that way. Or somebody with HHS, for example, someone with type 2 diabetes, does not have an insulin deficiency, okay? They have insulin in their body, but they're not able to use it effectively. So what happens is somebody with HHS, they have this, in some kind of setting, for example, viral illness again, they become sick, their glucose requirements increase, but they're not able to meet that with insulin that they have in their body, so they're not able to regulate it properly because they have some kind of insulin resistance. That's what's a hallmark of type 2 diabetes. So it presents similarly, but the fact that they still have insulin in their body rather than DKA, where they have no insulin at all, means that they do not produce ketones to prevent starvation. So the reason that we get ketones in DKA is because it's a starvation ketosis. Whereas in the HHS, it's not a starvation ketosis. We still have insulin that is able to use glucose. So that's the biggest difference. So then again, imagine we're in an OSCE. So one of the really good acronyms for DKA is something called SPIDER. So let's say we have a patient coming and then the examiner asks us, how will you manage this patient? There's a few important things that you need to do. The first one is always supportive, okay? So your ABCs. So you want to NGT, I don't think that's a good first line actually. But if they're unconscious, you want to intubate them, for example, you want to make sure the airways are patent, you want to give them oxygen, and you want to insert some cannulas and give them some fluid. Okay, so not all patients require a fluid bolus, but what happens is that if we do give them fluid, it can often correct the acidosis that they have. Okay, so the next one is potassium. So before we correct potassium, we want to do an ECG to assess if they have hyperkalemia or not. And when we do commence it, it's usually 40 millimoles an hour. Okay, then the next one is insulin. So we'll just combine these two together because usually what happens is that it's a acrapid infusion with dextrose at the same time. So 5% dextrose with some few units of acrapid in the same solution that you give to the patient over a particular period of time. Okay. Then the next one is examine. So make sure they're nil by mouth until stable, which means that so you can monitor how much glucose is going into them and how much insulin you need to give them, which is why you want to keep them nil by mouth. And you want to observe them, especially for things like seizures and any other neurological sequelae of DKA. And then the last one is just explain to them what's happened to them. Okay. Why do you need to give them a DKA? Okay.
Maybe because of dehydration.
Okay. Well, that makes more sense. Electrolytes. We can have that there. Electrolytes. Okay. So the next one is, so we have a young 22-year-old male. He has a 3-day history of dysuria and a 1-day history of heavy urethral discharge. So examination confirms the discharge and he has some perimeatal redness. So what do you think he has as a diagnosis? Gonorrhea. Okay, why not chlamydia? Maybe quick, and also the fact that he has heavy urethral discharge, and gonorrhea is also usually some kind of foul-smelling discharge, rather than a chlamydia, which is just your pussy, sort of like creamy-looking white discharge. Okay, so in this case, what are we going to do? So there's two options really. So either we could do a swab, or we could do a swab for MCS, or we could do a swab for chlamydia and gonorrhea PCR. So what would you do? No, good. That's it. What would we do?
MCS?
Why MCS?
Because you want to give the medication, see whether it's sensitive to it or not.
Okay, so that's true. That's correct. Okay, so we have J, which would confirm the diagnosis. We would confirm the fact that he had chlamydia or gonorrhea, but it wouldn't actually guide our management strategies. So what's important is for the MCS, for example, gonorrhea is often cephalosporin resistant. So by doing the MCS and getting the sensitivities back, we can guide the therapy that we give them and identify whether this is a cephalosporin resistant type of gonorrhea, which might then change what antibiotics we give them.
If there wasn't MCS and it's just a two PCS, what's the difference between the first pass and swab?
Which one?
So D and J.
When there is discharge, you can swab. When there's no discharge, you need first pass.
Yeah, and first pass is often you can diagnose other STIs at the same time as well. So people at home, so Max says when there's discharge, swab rather than first pass. Okay, so this is from the STI guidelines. Okay, Australian STI guidelines, which actually shouldn't be your first thing you use. Definitely use ETG for management because this actually differs from ETG in some parts, but as a tool itself is actually pretty useful. So what it tells us is that the PCR, so PCR versus MCS. So MCS is required to guide antibiotics, and the PCR is used to confirm what the diagnosis is, which is why MCS is the best answer for this question. Okay, next question. We have a 34-year-old, previously well female, presents with a painful perianal ulcer, present for 4 days. She thinks that she has had it before. It's a tender, small, shallow ulcer on a red base. So what is this? What was it? Herpes. So HSV. So what would we want to do? Which option is it? K. Yeah. So herpes simplex, that's correct. So the most common cause of genital ulcers is HSV. Okay. But that's the most common cause in Australia. So there's a few other things that can cause you to have genital ulcers, which we'll talk about. So that's how HSV will look like. But these are other causes. Look at what I do for you guys. I had to look at all of these pictures and then put them here. Okay. So HSV, is it there? Yeah, there you go. So HSV is the most common cause in Australia. So that one is HSV. But there's 3 other different things that can give you genital ulceration that all differ in incidence depending on where you're from, how it presents, etc. Okay, so what is this? Does anybody know what this picture is? So this is called chancroid. Okay, chancroid. So this is a rare form of genital ulceration that presents with lymphadenopathy a lot of the time. So swollen, painful lymph nodes specifically. Okay, so that's called Buber formation, where you have these painful swollen lymph nodes, and this is more common in males than females. Okay, and it's associated with people who are sex workers. Okay, so sex workers, that's who usually gets it. Okay, and then almost all cases are symptomatic. So being symptomatic means that it's very painful. So other places that it's endemic to is Africa, so sub-Saharan Africa, as well as Asia, apparently except Thailand, according to that STI guidelines document. Okay, now what is it? So what is the organism here? So it's Haemophilus ducreyi. Okay, Ducreyi. Okay, so that is what it's due to, and how it's described is these multiple. So you have multiple, so more than one painful genital ulcers with these ragged, undefined, undetermined edges, which typically occur on the prepuce or in the sulcus or in your butt or in between. And what you do, you'd give them azithromycin plus ceftriaxone. So that is called chancroid. All right. So then the next one, you guys will probably be able to diagnose this. Does anybody know what this is? Yes, one of this is syphilis, and this one is syphilis.
Oh, yes.
Okay, so syphilis organism is treponema, so we know that treponema palladium. Okay, so patients present with these genital ulcers or chancroids that are usually painless. So compare that to this, which is nearly always symptomatic. So chancroid is always symptomatic. Syphilis is painless. Okay, and the ulcers are usually also non-tender and has these well-defined margins. So compare that to chancroid, which has these ill-defined, very raggly margins. Syphilis has well-defined margins, but it still has this indurated base. So then the last one, does anybody know what the last one is? No, this is donovenosis. Okay, so warts gives you warts. It doesn't give you ulcerations. So this is donovenosis. Okay, so the organism here is Klebsiella. So Klebsiella granulomatosis. Okay, so Klebsiella granulomatosis is also rare. Okay, but it should be considered in all patients who are returning from areas where the disease may be endemic. Okay, so where is it endemic? So Papua New Guinea. Okay, Southern Africa. So not South Africa. Southern. Oh, actually, that is South Africa, isn't it? so South Africa, India. Okay, and parts of South America. So another SA. Okay, so it's relatively painless. Okay, so relatively painless. So relatively painless. And it can result in your anogenital ulceration. Okay, now the lesions can be of several different types. First one is you can have these ulcerative lesions that have this shallow base, which bleed on contact, and that is where you get this beefy red appearance, or it can be ulcerative plus proliferative, which is a combination of many different types. So that's donovenosis. That one is syphilis. That one is HSV, and then that one is chancroid. So how do we differentiate them? So remember, this one was painful. This one is also very painful. This one does not have pain, and this one often does not have pain. The ulcers in this are very well defined. The ulcers in this are very deep and have ragged different edges. These are often beefy red due to the fact that it's a granulomatotic disease. And HSV is the description that you got in the previous question. So we have this painful perianal ulcer, and it has a red base, etc., etc.
You remember donovenosis is red, because like Klebsiella has like red color, like exposure.
Oh, true. Nice.
It's like similar, but there was a question, like beefy red is the buzzword. I think there was a question a few years ago, like beefy red ulcer, but no one knew what it was.
Yeah. So 4 causes of genital ulceration. So important to know, you have to consider where the patient is coming from to decide whether that's the cause of the ulceration or not. Cool? I'm losing my voice. Okay, so we have a 56-year-old homosexual male, previously well, has malaise, widespread, non-specific rash of his palm and soles. He has enlarged lymph nodes in his axilla. He is careful to practice safe sex with his casual partners. What does he have? Syphilis, so what would we do? Which option from here? Because actually, I actually never read the options. Which one is that? Are you sure syphilis astrology? There's only syphilis option in there, isn't it? Yeah. Okay. So what symptoms? So what is this? How do you know this is syphilis? I mean, there's no description of an ulcer here. Yes, secondary syphilis. Okay. So that is a picture of what you might get with secondary syphilis. So rash on your palms and soles is typical for syphilis. So that's called secondary syphilis. Remember, there's 3 stages. So also the fact that he practices safe sex makes HIV less likely. Okay. But syphilis is still possible. And the fact that he has this fever, malaise, headache, so these systemic symptoms of this lymphadenopathy, that happens in over 90% of people who have secondary syphilis, okay? So the rash is usually generalized, can involve the trunk, but might just affect the palms and the soles. And thank you so much. What would you choose A for? N? What preparation and microscopy for some kind of vaginal discharge likely? Okay, all right. So, what else did I want to say? So, other things you can get with syphilis, especially secondary, so you can get something called condylomata lata. You guys have heard of that? Which are those water growths, especially in the anogenital areas. Just remember that. There might also be neurological symptoms. Okay, so cranial nerve palsies. You can get some ophthalmological signs of meningitis. And if untreated, will slowly resolve over a period of weeks, but it might recur. So next question is important. Okay, so we have a 43-year-old. He returns to get results from his most recent test results from serum drawn on that date. He's asymptomatic, but he has this as a regular screening because he's sexually active. So what do we see? We see this one is reactive. What is this used for? Syphilis. How do we treat syphilis? Benpen. That's not benpen. That's benzathine. So keep that in mind. I'll explain that in a moment. So first of all, what do we do for syphilis? How do we screen it? So there's a few things that we need to do. Okay. So if we're talking about the test, okay? And we're talking about the site, for example. So normally what happens is that there's a few serological tests that we can use. One sec. Okay, so serological usually first is the ELISA Hall immunoassay. I think it's called ELISA Hall. Okay, so first of all, either that or they can do the TPPA or the TPHA. Okay, so what do those stand for? So that stands for the treponema palladium. What is it? Treponema palladium particle agglutination. Okay, so that's TPPA, and then TPHA is treponema palladium hemagglutinin agglutination. Okay, and then RPR stands for rapid plasma reagent. Okay, so what normally happens is that somebody will get an EIA, or they'll get the TPPA, or they'll get the TPHA. Okay, but usually the EIA is the most one that's commonly used. And then if that is reactive, then they're going to have confirmatory testing. Okay, so confirmatory testing will be either the RPR or again doing the TPPA or the TPHA. Okay, so if somebody, now the reason for that is if somebody's been previously treated for syphilis, the TPPA or the EIA are usually positive for life, which is why you need to do the rapid plasma reagent, so the RPR, which can detect reinfection or treatment success. So what I'm trying to say, because I'm very hard to think this week, so these ones can be positive for anybody who's had syphilis in the past. So if that's positive, and if that comes back as reactive, we need to do the RPR to diagnose whether they've become reinfected, or for example, if their syphilis treatment has been effective. So the answer, yes, answer is benzathine penicillin. That's not benpen. So benpen is benzyl penicillin. So benzathine penicillin is just your simple penicillin that's had some sort of salt attached to it. Okay, so benzathine salt. So what the salt does is that it changes the characteristics of how that's absorbed in your body. So for example, benpen is something that's given IV. Okay, normal penicillin is something that's given orally. Benzathine penicillin is something that's given intramuscularly. So it changes how it's absorbed in your body. So benzathine is IM, benzyl penicillin is IV, normal penicillin is per oral. Okay, that's all you need to know.
Wait, so sorry.
Benzathine penicillin, also penicillin G, and the other one is moxicillin penicillin, and penicillin B.
Yeah.
Obviously that before. And then penicillin.
Wait, so this one's iron and then is iron.
Yes.
Okay, cool.
So benzyl, okay, benzyl.
It's a relatively simple treatment because you can just inject it once and it'll last like a week and then just come back.
Okay, so do you see the difference? Benzyl, benzathine, they're just different types of salts that are attached to the penicillin. So what's important about that, for example, let's say we have a small toddler or a young child who has streptococcal infection in their throat. Okay, that's a patient that's not going to tolerate having oral penicillin therapy, you can imagine. So that's why using something like benzathine penicillin, which is an intramuscular injection, might be more appropriate in that age group. Okay, very good. Okay, next question. So we have a 28-year-old sexually active. And the other thing is that somebody who is, especially somebody who has men who have sex with men, they should have quarterly testing for syphilis and the CD4 count. So that's something they should just have normally, even if they're asymptomatic, which is exactly what this patient is presenting with. So he's asymptomatic, but he's sexually active. It does not say that he's an MSM, but regardless, that age group needs to have quarterly testing. Oh, does it? Oh, there you go. What a coincidence. Okay, next one. We have a 28-year-old sexually active heterosexual man, raised lumps on his penis, present for 3 months, slowly spreading. So what causes these raised lumps? HPV. Okay, and that HPV doesn't need to be treated. Okay, but people get it treated for cosmetic effect. And in that case, what do we use? Imiquimod. Okay, so imiquimod is like an immune agent. Okay, so it signals the toll-like receptor 7, okay, and that causes an immune reaction to occur that removes these warts, and therefore imiquimod can be used for a lot of other skin lesions. So for example, basal cell carcinoma, actinic keratosis, these are all things that imiquimod can be used for. I'm pretty sure it's a cream. Okay, next question. So we have a 22-year-old. Yeah, you can also do cryotherapy, that's correct. 22-year-old, sexually active, heterosexual, has a pap smear. So the doctor said have an extra test for some kind of infection. So she had a urine test, which is likely a first pass urine because she doesn't have any symptoms of the discharge, which is why she hasn't had a swab. Okay, and she's been urgently recalled for review and she's asymptomatic. So what does she have? She likely has chlamydia. In that case, what will we treat with? azithromycin. Okay, so chlamydia is typically asymptomatic, especially in females. Okay, it's the second most reportable notifiable disease in Australia. Okay, and I'm pretty sure it's also the most common STI altogether, especially in Melbourne. Okay, so he's diagnosed on the first pass urine that has been happening here. She doesn't have an ulcer, so she doesn't need a swab. So azithromycin is a macrolide, it's broad spectrum, which is why we use it here. Okay, now just to go through some of these other options here. So amoxicillin, we know that. We know benpen, so benzathine penicillin, sorry, now I'm making a mistake. We know ceftriaxone, which is gram-positive. Chloramphenicol, what do we use that for? Eye drops, okay? So chloramphenicol is usually only topical, okay? It's not used systemically because of the risk of bone marrow suppression, okay? That is why it's only used as ear and eye drops. Ciprofloxacin, what do we use that for? Actually, we'll talk about that. There's another slide where we'll talk about different antibiotics. Okay, so
Can you use doxy for chlamydia as well? Or is it a
I think it's
different?
better. I think it's
so it's azithromycin. So typically,
Or doxy, so that's doxy 100 milligrams.
so I'm pretty sure doxy. There's specific reasons why you'd use it by itself,
Okay.
but empirical therapy is usually azithromycin. But you're correct. There's like on ETG, will tell you why you use doxy instead. Okay, so. Like before, so we're just going to go through some options. So we're going to go through the options list before we look at the questions to help us understand the question better. Okay, so from this option list, the first option is atopic eczema. Okay, so I didn't have the effort to actually do writing this time, so that's why I'm just going to do it by pen. So very quickly, because there's quite a few options here, give me the quick definition of atopic eczema. So common, okay, chronic. I'm the one talking. Anybody else? Relapsing, okay. Okay, skin. So inflammatory, okay. Disease of the skin, okay. Inflammatory disease of the skin. So children typically tend to grow out of it, okay, but they often experience lifetime of sensitive skin. So therefore, they have to avoid certain professions. For example, let's say a hairdresser, okay. In an infant, it usually presents on the face and the trunk, okay. So face plus trunk. Whereas in a child or an older child or an adult, it would present in the flexural surfaces, okay. So adults would be in the flexures, so flexural surfaces, the neck, the wrist, the ankle, etc. Okay, whereas in the child, it'll present in the face and in the trunk. So what are risk factors? So what are risk factors for somebody getting a flare of atopic eczema? So there's a mnemonic that we can use. It's called scratch. Okay, have you guys heard of scratch? Okay, so the S stands for soap. Okay, so particular soaps can cause irritation. What is C? C is different types of chemicals, so hand washes, dishwashing liquids, your washing powders, etc. R stands for rough. So in this case, it actually stands for sand. So for example, children who play in the sand pit, that can cause them to, it can cause the eczema to get worse. Okay. A is allergens / animals. Okay. So people who have some kind of allergy, for example, to dust mites or household pets, they can get eczema to come back. Okay. T is for terrible infections, and it is such a terrible mnemonic, isn't it? Terrible infections, any kind of. So remember, viral infection, anything that can cause a chronic condition to become acute is usually due to some kind of precipitant. So all of these things in the list are some kind of precipitant. So terrible infection, clothes and linen. Okay, which is why in an OSCE setting we would explain to the mother, replace all of their bed sheets with like soft cotton stuff. And then the last one is heat. So we tell them, please don't have hot showers.
Okay, yeah.
Oh, and azithromycin is also, is it an iron injector or is it oral? Oh, okay, so that's not it. Okay, so risk factors, so precipitants for getting eczema. Now, eczema is the only one that I'm going to go into a lot of depth in because you might very, very reasonably have it on an OSCE station. So if we were in an OSCE setting and they asked us, what is your management of this patient? What would be our approach? Now, I've talked about this. I think a good way to approach management in an OSCE is in an OSCE is 3 ways. So and that's using the 10-step management plan. So that's immediate management, okay? Then it's long-term management, and then it's management that is specific to this condition, okay? So under immediate always comes 3 key headings, okay? Do we need to do any investigations right now? Do we need to refer you to anyone right now? And is there any other immediate management that we need to give you? Like, for example, in the case of anaphylaxis, we need to give them immediate intramuscular adrenaline. Okay, so in this case, investigations, what might we consider? There's a low chance we might consider, for example, skin prick or some kind of allergy testing, but otherwise we don't need to. Referral would only be if it becomes more severe, and in that case, we might consider referral to a dermatologist. That would often be in the setting where they require some kind of systemic agents, for example, methotrexate, cyclosporine, azathioprine, or in some case, if they require some kind of stronger steroid, we would consider referral to the dermatologist. Do they need any immediate management? They don't. Okay. So long-term management of atopic eczema. So this is something you really need to know for your OSCEs. So I'll start with you, Trudy. What do you think is a long-term management for eczema? Yeah. Yeah, perfect.
Avoiding like walls, use like moderate soaps and emollients.
Yes. So you would avoid all of those things that we went through in the last slide, all of those precipitants. So we'd avoid, sorry? So we'd avoid soaps. We'd avoid particular chemicals. So we would use eczema-friendly hair cream. We use eczema-friendly what do you call it? Shampoo. I'm very cool. So shampoo, etc. We would avoid particular chemicals. We would tell them don't play in the sand pit. We would tell them, wear some cotton clothing. Only take warm showers that aren't particularly hot. Don't get an infection if you can avoid that somehow. Okay, so avoid all of those. And as you very correctly said, we want to use ointments, okay? So moisturizing is the mainstay of treatment in eczema, because what we're trying to do, we're trying to prevent dryness. We're trying to prevent humidity and something else. There's three things. Okay, so then the last one is specific management for eczema, okay? So specific in this case has a few broad categories, okay? Now the first one is flares, okay? If they have a flare of the eczema. Other one is itching. Okay, I know I spelled that incorrectly. Itching. And then another one is if it becomes lichenified, okay? So this is what I mean by specific management. So if they have a flare of the eczema that is particularly bad, what we can do in that setting is we can give them steroid creams, okay? Now, steroid creams are very important that you know what the risk factors are and you know how to explain it to a patient. So if the eczema is not resolving, we can prescribe some over-the-counter steroid cream. So usually the way you use it, you use the moisturizer first, you wait 30 minutes, and then you use the steroid cream just in the areas that are affected, okay? You try to avoid places like the face. Now, the reason for that is because if you use steroid creams for more than 3 weeks, it can cause your side effects of steroids. So in this case, the important side effect is skin thinning, which might actually make the skin worse. So less than 3 weeks is the time frame in which you want to use your steroid creams, because otherwise it can result in those side effects as well as systemic symptoms. Now, itching, how do we deal with itching? Does anybody know? So okay, conservative management first, okay? So we can use warm dressings, especially on the areas. So getting a bandage or some kind of gauze, putting it in some warm water, and then putting it on that area to prevent irritation. Keep the nails short, okay? So we can see this little baby has a lot of excoriations on the face, likely because they've been itching it. So keep the nails short, and you can use some antihistamines in this case, okay? And if it's still not improving on the antihistamines, I believe, but I'm not sure, I haven't confirmed it, you can use doxepin, which is a tricyclic antidepressant, but again, confirm that, I didn't check myself. And then the last one is if it becomes lichenified. So lichenified is when you get those really hard, like white sort of lines. In that case, you can use tar creams. Okay, so that is your specific management for eczema. So remember to go through that list. Immediate management, long-term management, and then specific management, and you'll get through your OSCEs with ease. Okay, so then the next option, okay, is plaque psoriasis. Okay, so definition, does anybody want to give me a definition?
This context, right?
Is plaque. Okay, so this is chronic. Okay, so chronic also means lifelong. It's incurable. Okay, it's autoimmune. It's inflammatory. Okay, it's an inflammatory condition that is characterized by these well-demarcated pruritic. Okay, pruritic, scaly red patches. Okay, so that's how we define plaque psoriasis. And it can be managed effectively. That's very important that you tell your patients that, especially in your epidemiological prognosis section, and that it cannot be passed on. So that's another important thing you need to say. All right. So then the symptoms. So what kind of symptoms do we get? So typically, it's on the extensive surfaces. Okay. So extensive surfaces, which is how you differentiate it from eczema. So eczema is usually on your flexural surfaces. So scalp, your hairline, your elbow, your knees, your back. And complications that you can get nail involvement, and you can also get arthritis. So around 50% of people, 30% of people who have who have psoriasis can have psoriatic arthritis. 50% of people can have nail involvement as well. So there's a particular complication that you need to tell the patient. Another thing is, do you guys know what the Koebner phenomenon is? Thank you so much. Sorry? Yes, okay. So psoriasis in the area of a trauma, okay? So that's called the Koebner phenomenon, and that's most common in psoriasis, okay? Now the management. So psoriasis is the second thing that I'm going to go through in-depth management with. I didn't put it into OSCE style for this one. But number one, we always start with conservative, okay? So warm baths, okay? So warm baths. So you can do that with oil, you can do that with tar soaps, you can liberally use creams that can help you reduce some of the symptoms. The second one is sunlight. Now, why is sunlight important? Sure, it's anti-inflammatory, you get UV exposure. So the UV exposure had decreased inflammation, which is why phototherapy is also something that we use for psoriasis. That is also a reason why we typically don't see psoriasis on sun-exposed areas such as the face, okay? So sunlight, it follows that we then do phototherapy, okay? Phototherapy, usually with UVB, with increasing exposure. The question that they might ask you in the OSCE STEM, the patient might ask you, will I get cancer from using phototherapy because it's UV? And what you tell them is that you are not at an increased risk. It's 24 sessions, so that it's over a long period of time, 24 sessions. So it's only a minimal exposure each time, so it doesn't increase your risk, but it does take a lot of time, okay? So that's your conservative management, okay? Actually, we didn't talk about triggers. So conservative management would also be avoiding the precipitants, which in this case is another silly mnemonic, which is nail beds. Have you guys heard of this one? Okay, so my who taught me YESPA last year taught me this, Dinesh. So NSAIDs, number one. So NSAIDs, anti-malarials, okay, anti-malarials. A very odd one, isn't it? Infections, okay. Now infection is very logical, thank you. So group A strep, particularly. Lithium, okay. Beta blockers, yeah. I'm pretty sure beta blockers have been on a past exam in relation to somebody having worsening of the psoriasis. Beta blockers, so emotional stress / estrogen. Okay, so somebody who's on the COCP can develop worsening of the psoriasis. The last one is developmental. So somebody who's going through puberty or menopause can have worsening of the psoriasis. The last one is sunburn and smoking, because smoking makes everything worse. So spirits, okay, spirits. Okay, so spirits. So conservative management, warm baths, so with oils, with tars, with emollients. The second thing I mentioned was going into the sun, avoiding all of these risk factors. And then I guess phototherapy is a conservative management because you're not giving them medication. Okay, then to go on to medical management, okay, very quickly. So first line, okay, actually, so the management for psoriasis is hard to tell you what to actually learn, okay? The reason for that is the management differs depending on how you look at it. For example, there's something called the PASI score, which is the psoriasis something severity index, which also differs in how you manage it, because that's defined from like mild, moderate to severe. But in general, what I'll teach you is that first line is a topical what? Steroid plus a topical vitamin D, okay? So topical calcipotriol, okay? So what this does is that irritates the skin a little, often used with a steroid, and it's used for the long term, okay? So it slows down the rapidity of cell division and it improves the maturation of the skin, because that is the reason why we get psoriasis. That's why it's always so red, because you have this rapid cell turnover. That's why it's so dry, that's why it's so flaky. It's always red all of the time. So giving them this will increase maturation first of all, and it decreases that rate of it decreases the rapidity of the cell division. Okay, so what you can tell your patients, and to look very fancy in your OSCEs, you can tell them that it's called Dovapet cream. So it's Dovapet. You can get it over the counter. Actually, I'm not sure. Actually, maybe you need a prescription. So you can get it at a chemist warehouse, and it costs $32. Okay, but if you're a concession patient, anybody who has a healthcare card, that cost is always like $5.30 for whatever medication they use. Okay, so that's Dovapet. Use it once daily on the areas that have psoriasis. Second line therapy for psoriasis is using that twice a day. Okay, and then third line. Okay, so third line is using coal tar. Okay, so what coal tar does is that breaks down the plaques, and like we said, you can also use that tar in your shampoos, in the shower as well. So it's very hard to actually classify that in your third class category anyway. Okay, but it's especially useful for scalp psoriasis because you can use it as a shampoo. Okay. So that's Dover, but that's how the cream looks like. But again, go back to what I just said of how the treatment differs. So for example, if you're using the PASI score, somebody who has moderate or severe, the treatment differs where we'd use more systemic agents, for example, methotrexate, azathioprine, vitamin A analogs, etc. Is that okay? Very cool. All right.
Could you tell them about like the injections?
Which injections?
Biological.
Yeah, so that's what I was just mentioning. That's why it's hard to tell you what to know because I don't feel like you need to know that much information. But what you would tell them in the OSCE setting is that if you're so psoriasis is usually very well managed with these conservative therapies that we have at the moment. But I just want you to know that if it's not managed, there are therapies that we can give you further down the line, which are more systemic, that you will need to see a dermatologist for, but that are also shown to be very effective in the management of psoriasis. So some kind of line like that is all I typically expect you'd need.
So does the GP manage psoriasis up until that point?
If you're needing any kind of systemic therapy, then you would refer to a dermatologist. Okay, so then our next options on the list are contact allergic and contact irritant dermatitis. Now both are forms of contact dermatitis. One is irritant, one is allergic. Okay, the difference between them. So irritant, okay, is secondary to like the corrosive or the chemical effects of a substance. Okay, that's why you get the redness, the scaling, the fissures, and etc. Whereas allergic, okay, is a type 4. So type 4 hypersensitivity reaction. Okay, so it's different in the mechanism of action, but they present very similarly. So allergic is not due to repeat exposure to the same agent. So it's not due to washing your hands. So allergic contact dermatitis is using a reaction to some kind of chemical or a soap that causes you to have these symptoms. For example, we might have seen in the YESPA mixtape a long time ago last year how there was a patient that was using a brass belt buckle and they had that little rash in that area. So that would be allergic contact dermatitis, whereas irritant would be due to the corrosive or chemical effects of whatever you're using. Okay, in both cases, the management is very similar. Avoid contact or avoid whatever is causing it and use emollients. So you can see that in this page, you can see it's very red. Very red is scaling. There's not necessarily blistering in this case, but the patient's hands don't look particularly good. So then the next option on the list was dermatitis herpetiformis. So this is just, this is classed as an immunobullous disease. Okay, immunobullous disease. We talked about why it's called herpetiformis because it looks like what you'd get with herpes, but it's not due to herpes. Being linked to celiac disease, and bigger symptom is prurigo. Okay, so prurigo is mildly different to pruritus. So prurigo means extremely itchy papules. Okay, which is what you get in dermatitis herpetiformis, and you get these vesicles on the skin, and the skin is a little bit red. The management that you give them, I'm not sure you need to know this, but is for your knowledge, is called dapsone. Okay, so dapsone is actually a sulfon antibiotic that historically used to actually be used for leprosy. So I'm not sure why it's effective in this case. Okay, next one, discoid eczema. So discoid eczema, how is that defined? We have these scattered, okay, so scattered roundish, that's why it's called discoid, roundish patches, okay, of eczema. They can be extremely itchy. And another name for, what's the other name for discoid eczema? Yeah, nummular. Okay, so nummular eczema is another name for it. And usually it's not, usually it's due to the normal things eczema is due to, but in some cases it can be secondary to Staph aureus. Okay, so typical in young adults, it's usually symmetrical discs of eczema and crusting. Some are impetiginized, so you could argue that looks a little bit yellow, but I'm not 100% sure. Very pruritic. Differential in this case is, so what's the biggest differential to this picture? No, tinea, okay? So tinea corporis, okay? Why is tinea a differential? It's common and it also presents with these central lesions, but what you see with tinea is centrally clearing, okay? So in this case, I mean, that's not centrally clearing. You can still see some blistering and some redness in that location, whereas with tinea, you'll see in the picture coming up that there's definitely central clearing in that location, and you might also see satellite lesions in other locations on the skin, okay? So discoid lupus eczema. Okay, discoid lupus eczema. So that's a very big topic, but lupus erythema, so lupus, that's just a group of diverse persistence autoimmune plus inflammatory diseases that often affects the skin, okay? So DLE, so discoid lupus eczema, is the most common chronic form of cutaneous lupus. Okay, so DLE is a form of cutaneous lupus. That's important because lupus is just many different types of things. So this is a cutaneous form of lupus. Okay, so what is it? So how does it present? It's characterized by these persistently scaly disc-like. So that's a little bit of a disc. That's a bit of a disc. Plaques that are on the face. Okay, so face, ears, and it might also cause a little bit of hair loss. Okay, so it's often diagnosed from its distribution into the sun-exposed areas and the clinical appearance of these plaques. So the other dermatological features that you can get with cutaneous lupus are your malar rash. Okay, so malar rash, I believe I have a picture. So malar rash looks similar to acne. Okay, not in this picture, but it can look very similar to acne. So the way that you differentiate it is that the acne does not spare the nasolabial fold. Okay, so what you see here is that the nasolabial fold there does not have any redness and it does not have any skin changes. Something like acne, you might get skin changes in that location. Does that make sense? Okay, so I don't want to go through the antibody screen. Okay, so next one, erythema annulare. Okay, so erythema annulare is just a descriptive term. Okay, it's a descriptive term. Okay, so it refers to a number of chronic annular and erythematous skin eruptions that can happen at any time throughout your life. So what is described as is these small, that wasn't necessarily small, but they're pink red spots, pink/red spots, or these plaques that slowly enlarges and forms a ring shape while the central area flattens and clears. So what you can see is that you can see here, so that one is very small, right? Okay, so what happens is that slowly expands into something like this. So it slowly gets bigger and bigger. So it probably started something like that and it got bigger. And what happens during that time is that the central part of it, it becomes flat and clear. So that is your erythema annulare. So this is, I mean, it could be, it's still very similar to how tinea might present, but this one is much more slower. Okay, so the expansion is like 2 millimeters to 5 millimeters a day. Okay, until they reach a diameter of about 6 to 8 centimeters. Okay, so that's usually how big they get. Tinea, I'm not sure how it differs to tinea, to be honest. I don't know too much about it. I don't know. I'm really not sure. But erythema annulare can be due to many different things: so bacteria, virus, fungi, tuberculosis, sinusitis, candida, tinea. So, and also many other drugs. So you can have a secondary to like chloroquine, hydrochloric chloroquine, so like your RA drugs, your malaria drugs. You can actually have a secondary to liver disease, to Graves' disease. So there's many things that can cause erythema annulare, which is why it's just a descriptive term rather than a disease process. Okay. Okay, so this one is guttate psoriasis. Okay, so guttate psoriasis, how does it differ from pityriasis rosacea? Because both of them, you get these guttate sort of lesions. So guttate is just a word that stands for raindrop. Okay, so raindrops, that's how, that doesn't necessarily look like a raindrop, but that's how it's described regardless. So with guttate psoriasis, typically what happens is that it's secondary to strep throat, or at the very least, that's what you'll see in an exam question. That's not always the case. So you have a sore throat 2 to 4 weeks before actually having the infection, but that's not a common presentation. Okay, so the way that it differs from pityriasis or rosacea particularly is that, how does it differ? Is that with pityriasis, you have your herald patch first, and then you have the expansion of all of these other symptoms. Okay. The other thing is that with a guttate psoriasis is that often the rash comes on very quickly. So after your 2 to 4 weeks prodrome of having your viral symptoms, your sore throat, these rash just comes sort of out of nowhere very quickly. Whereas with your pityriasis or rosacea, you have your herald patch, then you have your slow progression of your more disseminated rash. Okay, so that's guttate psoriasis. Okay, so usually self-limiting as well. And how is it described? So we just have these multiple lesions on the back sometimes with a fine scale. Okay, so this is, what is this? This is, because I forgot to put the little thing on the top. This is lichen planus. Okay, so lichen planus, there's many different types of lichen planus, and I would suggest you to read up on it because you might have an exam question on it, because it's also implicated in ONG when you can get vulval lichen planus or just genital lichen planus. Okay, so lichen planus is many different things. But when we're talking about lichen planus, for example, in these pictures here, there's several descriptive terms that you can use. So that your 6 P's for lichen planus. So the first one is planar, okay, which just means that it's flat topped. Second one is that it's usually purple, okay, that it's usually polygonal, okay, so it's a polygonal shape. That is pruritic, okay, that it forms plaques. And is that 6? 1, 2, 3, 4, 5 papules, and then it forms papules, okay. So these are your 6 descriptive terms for somebody who has lichen planus. So planar, purple, polygonal, pruritic, plaques, and papules, which you can see in all of these images. So like I was saying, so lichen planus can be oral, it can be vulval, it can be penile, it can be cutaneous. So there's many different ways that it can present. So what we can see in these pictures here is first one is just your classical violaceous. So violaceous. So that just means purple. That is polygonal. So you can see that it's multi-shaped, and that is a plaque. Okay, so your classical description of lichen planus. Then this one down here is something called a Wickham striae. Okay, do people know what Wickham striae is? So it's just the white lines that you can see on the surface of the lichen planus. Okay, now and then this one. So these are guttate plaques. So remember, guttate just refers to the fact that it looks raindropped in shape. And then the last one is hypertrophic. Okay, so hypertrophic, that's something that you can also get with lichen planus. Now another symptom, it depends on what kind of lichen planus you get. But for example, if you've had oral lichen planus, they can complain of burning in the mouth because it affects those mucosal surfaces. So definitely read up on lichen planus. I think it's an important topic. Okay, so then this next picture, does anybody know what this is? Chlasma, what's another name for it? Okay, now those are not the same thing, okay? Well, actually, the same condition. They describe the same thing, but it's actually not correct, okay? So chlasma, etymologically, actually means green, okay? Whereas melasma means brown. So that's why melasma is the more correct term for this presentation. So this is just a chronic skin disorder that results in this symmetrical, blotchy, brownish facial pigmentation. So that it's not particularly bad, but it can just result in some cosmetic disturbance, and therefore it can affect the patient's psyche, which I didn't mention before. Always remember, for any of your dermatological conditions, if you're in an OSCE, one of the complications is always psychological. So you always need a patient, how has this affected your social life or affected your confidence, etc. Always include that somehow. So same thing here, just affects people's cosmetic appearance, more common in females than males. Well, the only thing you need to know about that is that about 1/4 of affected women are on the COCP. So hormonal related. So often can happen after pregnancy for that reason. So this picture is a Herald patch. Okay, so therefore the condition is pityriasis rosacea. So pityriasis rosacea is just a viral rash which can last from 6 to 12 weeks. It can last a long time. So it's characterized by you getting this Herald patch first, that is then followed by these similar smaller oval red patches that are located mainly on the chest and the back. Okay, you're usually self-resolving, but if you had to manage it, what you would do is that you can use some antihistamines, okay, or some topical steroids to decrease the itching, okay? But if you do use steroids, what happens is that, yes, it does decrease the itching and improves the rash, but it delays the time for your new skin to match your old skin. So there's a difference in color. So we know that when let's say we get a cut or we get some kind of burn, like you can see on my hand, you notice that the skin is brown there, okay? So if we use steroids, very similarly, the new skin that we're developing will be a different color to the new skin because of the side effects that steroids have on skin, okay? Otherwise, direct sunlight is another measure because that can reduce or it can increase the resolution of the lesions. Okay. So then this is, does anybody know what this is? So this is pityriasis versicolor, okay? So that is a very common yeast infection of the skin. So it's due to a yeast. Does anybody know what the yeast is? It's called Malassezia, okay? So Malassezia yeast, okay? So what happens is that you have these flaky discolored plaques, okay? So these flaky discolored plaques you have these multiple discolored plaques, okay? So Malassezia is a normal skin flora, so part of your normal biota. And what happens, the reason that it goes white is that it's thought that the chemical that's produced by Malassezia diffuses into the epidermis and impairs the function of the melanocytes, okay? We know melanocytes are there to produce pigment, so the chemical from the Malassezia impairs that, so therefore you don't get the color, okay? You can also get different colors of pityriasis versicolor, which is why it's called versicolor. Versicolor refers to the fact you can have many colors. You can also have pink. So pink happens because of inflammation. Okay, again, secondary to the yeast. Now, how do we diagnose? And diagnosis is important just because I've seen that on something before. So diagnosis is usually with Wood's lamp. Okay, so Wood's lamp is not specific for anything. Okay, Wood's lamp just refers to a black lamp for examination. And you might also, so what you would see under a Wood's lamp is some yellow-green fluorescence in the affected areas. Okay, so if I put the black light on this location, it might look yellow-green. Okay, so yellow-green just like the color of my pen there. Okay, you might also do microscopy. Okay, so you might also do the microscopy with a potassium hydroxide, which we also do for some vaginal discharges, to look for the hyphae and the yeast cells. So that's what we use potassium hydroxide for. So we know that in vaginal discharge, we use the hydroxide for something like bacterial vaginosis. And we also do it in this case because it's due to a yeast. Okay, if we do a culture or if we do some kind of biopsy, what we'll see is this. Okay, so this is called a spaghetti plus meatball appearance. Okay, so the reason for that is you can see these little spores and you can see these little lines. So that's how malassezia will look under the microscope. So spaghetti and meatball appearance. Okay, management, just with any kind of azole shampoo. So remember, azole is just that antifungal. So any kind of antifungal shampoo. Okay, now how does this differ from vitiligo? Yes, okay. So vitiligo, so the reason I'm asking you this question is because both of these have removal of pigment. Okay, so in pityriasis versicolor, the removal of pigment is a hyperpigmentation secondary to the yeast. Okay, whereas in vitiligo, as you correctly said, autoimmune is due to no pigment in the first place. Okay. So I should say, so vitiligo more correctly is hyperpigmentation, whereas versicolor is loss of pigment. Okay, does that make sense?
But doesn't it become white? Like, isn't that like a loss?
Okay, autoimmune versus acquired process, I guess is the best way.
Versicolor makes the skin darker, right? And what's this?
Yeah, versicolor, many different color changes you can get.
Then it's not really-
Changes to pigment. Okay. All right, so this one, what is this? Okay, so this is tinea. Okay, so this is tinea because what do you see? You have central clearing. Okay, so this is an erythematous patch with this collarette on the margin. Okay, and in the paleness. Okay, so this spreading scaling rash with central sparing is tinea corporis. Okay, so tinea corporis is also called a ringworm. Okay, that's the colloquial name for a ringworm, but it's not due to a worm because somebody has asked me that question before. It's not due to a worm; it's due to a fungus. Yeah, fungus. Tinea corporis. Yeah, so it's due to a dermatophyte fungus. Okay, so now we've gone through most of those options. Now we can finally get to the questions. Oh, we're only up to question 20. Oh my god. Okay. Okay. What do you think she has? Okay, so she has slightly itchy. Okay, she started with a small round patch that has now increased. Pityriasis. Okay, so she started with a herald patch. So that's pityriasis. So this patient, yeah, had these small patches, so affecting the arms. So for example, the flexural surfaces rather than the extensor surfaces. Began 2 months ago, gradually worse. Typical lesions. So this is discoid eczema. It looks exactly like discoid eczema that we saw in the previous pictures. So that's discoid. Now this patient, so it's a bit hard to see there, but what you'll notice is that this has turned a little bit pink. So it's different to the pigment around the body. So this is pityriasis versicolor. Okay, very good. Okay, so this is an important question actually. So Kelly Lawn, so she has children. She has a bruised left eye. Okay, so essentially what happens is that the doctor thinks that she might be being abused at home. So then the patient asks the doctor, are you going to report this? Or are you going to tell anyone about this? And then what do you say? So the question is, am I allowed to report this? Yes, okay, why? Okay, so there's a duty to maintain confidentiality at all times, and there's only a few reasons why we can break confidentiality. First one is in public interest. So for example, if we think there's a danger to national security, if there's some kind of fraud or some kind of legal activity, a legal act or matter that is in the public's interest. Okay, so an example of that would be like an infectious disease. So somebody has HIV, is reportable, so that's why we can break confidentiality in those cases. If there's some kind of legislation requiring the doctor to break confidentiality, for example, a court ruling, okay, if there's for the health of the person concerned, which, you know, it kind of makes it harder because you can maybe interpret this as this affects the health of the person concerned, but then you can probably use that argument for a lot of things. So unless there's an acute risk of life-threatening, something that's going to threaten the patient's life, we still can't break confidentiality. So number 6, if there's mandatory reporting of child abuse, so that is why B is the correct answer. Number 6, if the patient has approved you to release that information. And number 7, if there's some kind of emergency and you need to update the medical or treating team. This one. What? Over that. Okay, so a 17-year-old has a 3-week history of fevers, odynophagia, loss of appetite, and lethargy. Monospot is positive, therefore they have EBV. Very good. With these simple questions, I'm just going to go through them quickly. Okay. Yes, so all of these are much more likely to happen in IDA than anything else. Okay, so that's why this is IDA, as well as all these symptoms. You know, she has rheumatoid arthritis. I mean, you could argue it could be something else, but it's the most likely, especially with a reduced MCV. All right, so we have a 61-year-old. He presents with painless lymphadenopathy, palpable splenomegaly, okay, raised white cell count with which are mature, reduced platelet count, reduced red cell count. So what happens? Increased white cells, decreased red blood cells, and decreased platelets. So his bone marrow is not working properly. Only one part of his bone marrow is working to produce all of these white blood cells. Therefore, he has CLL. So again, we've talked about that to some degree, not that one, in another one of the other lectures that we've done. So this one has hypersegmented neutrophils, B12. Okay, very good. Okay, so this person has been recently started on fluoxetine. Okay, they've got kidney disease, and now they're presenting with these non-specific symptoms, especially confusion. What do you think is going on here? Hyponatremia. Why? Yes, so that is a well-documented side effect of SSRIs in general. Okay, fluoxetine, the reason that it's used in children is because it's either short-acting or long-acting. That doesn't help, does it? It's long-acting, yeah, so it decreases symptoms of withdrawal. So the fact that it's long-acting in somebody with chronic kidney disease at the same time increases the chance that they're going to have some kind of changes to the sodium. Okay, so this person, 56, severe treatment-resistant hypertension, BP has always been normal. His blood previously been normal. So in addition to this hypertension, he now has fatigue, muscle weakness, cramping, headaches, palpitations, polydipsia, and polyuria. What condition is this? This is Conn syndrome, okay? Now, the reason you know there's Conn syndrome is because one of the causes, especially of muscle weakness, is hyperkalemia, okay? And Conn syndrome causes you to have hyperkalemia. So Conn syndrome is a well-known cause of having muscle weakness. So if we were to have a look at the pathophysiology, so what happens is that Conn syndrome is primary hyperaldosteronism, okay? Whereas something like Addison's disease is primary hyperadrenalism, okay? So consider Addison's as hyper and Conn's as hyper. So what happens is that with hyperaldosteronism, too much aldosterone, so you have too much activation of here, and this acts in the collecting duct on the sodium-potassium pump. So what happens is that this potassium keeps getting pumped in, and it gets peed out in the urine, and you get too much sodium into your bloodstream, okay? Now, another thing that I want to show you, that's why so therefore, what would the management be? How do we block aldosterone? Spiro, okay, Spiro is considered a MRA, which is a mineralocorticoid receptor antagonist, and that is also why in some conditions we can also use an ENaC blocker. So an example of an ENaC blocker, does anybody know? Indapamide, I'm pretty sure. So indapamide is important because it's something that we can also use in diabetes insipidus, okay? As well as the thiazide diuretic that we use in peripheral diabetes insipidus, okay? So nephrogenic diabetes insipidus, we can also use indapamide at the same time. So the thiazide diuretic is to remove the polyuria, polydipsia cycle that is due to sodium, and then indapamide is to reduce the retention of sodium in the first place, okay? So in this case, the answer is hyperkalemia. Okay. Okay, so this patient, 72, urgency, frequency of micturition, so polyuria, they have polyuria, constipation, they have back pain and confusion, hypercalcemia, so they have Thrones, bones, groans, etc., etc. Hypercalcemia. Now remember, I really want you to remember what I told you last time about hypercalcemia, usually asymptomatic. Only reason you become symptomatic is if you have a sudden acute rise. So it doesn't matter the level. What matters is the sudden acute rise. If you have a sudden acute rise, that becomes symptomatic. And then 90% of cases of hypercalcemia is either due to PTH, so hyperparathyroidism, or malignancy. So especially in this age group, you need to investigate malignancy. So with the next few, so just with these next few questions, I'll stop there. So I won't go on much longer. So just a few slides more. Okay. All right. So this picture, the pathology is here. Okay. So these pathologies come under a broad heading of osteochondrosis. Okay. So osteochondrosis has many different diseases under it. Okay. Of those diseases, those include Freiberg's disease. So Freiberg disease, as well as Kohler's disease, as well as anything else that gives you osteochondrosis. So there's many different things that can give you osteochondrosis. So osteochondrosis is just a descriptive term for the group of disorders that affect the progress of bone growth via bone necrosis. Okay, so that's why it's usually only typically seen in adolescents and children, because in adults the bone growth has already been done, right? So in Freiberg, so this is Freiberg's osteochondrosis. What happens is there is osteochondrosis of the metatarsal heads. Okay, typically affects the second metatarsal head. Okay, but the third and fourth might also be affected. It can be bilateral in up to 10% of cases, and it's most common in women, so females over males, who are around 10 to 18 years old. So, in that adolescent child period. Okay. So what kind of symptoms do they get? They get pain on the weight bearing. Okay. They get swelling and they get tenderness. Okay. And the reason you get it is probably due to some kind of vascular event, but it's, there's many different things that can cause it. They don't actually know. Okay. So histologically, Freiberg's, you have this subchondral collapse of the subchondral bone, you have the osteonecrosis, and you have the cartilaginous fissures. So what you can see here is that this metatarsal head looks very unusual compared to the other one. So you can see you have decreased lucency there, usually likely due to some kind of necrosis. You have a little bit of calcification there, and you have destruction of that metatarsal head. So that's Freiberg's osteochondrosis. Compare that to Kohler's. Okay, so this is Kohler's. Okay, and then this one is just childhood onset. So childhood onset osteonecrosis of the navicular bone. So what is the pathology? So I'll go around in a circle. Tell me when to stop. Yeah, there. Very good. So what you can see there is that is the navicular bone. Okay, so that is the navicular. Normally the navicular should be much bigger than that. It should be boat shaped. So what happens in this case, it becomes wafer-like and very thin. So you can appreciate that sort of looks like a wafer. I'm not sure what type of wafer, but a wafer nonetheless. Okay. So what also happens is that it becomes fragmented and it shows some sort of patchy sclerosis. So similar to osteonecrosis that you can get in any other part of your body. So childhood onset. Okay. Pediatric population, so usually 4 to 6 years old. Okay. And there's a associated male predilection. And again, usually it's due to some kind of vascular incident that's unknown. Okay, so often they'll also complain of some sort of soft tissue swelling at the same time. I honestly think it's very unfair that you need to know these kinds of diseases because they're so very specific. If you knew osteochondrosis was due to necrosis in the age group, I think that's good enough. But because it's on the past exam, you do need to know about it. If you want to know about the other different conditions, there's maybe like a list of 8. It's on Radiopedia. And then the adult version of this disease is called Mueller-Weiss syndrome. Okay, so Mueller-Weiss. Okay, which is just the adult onset of this navicular bone osteonecrosis. So if I was to define it, I would define it as, choose the same color. So navicular osteonecrosis. So let's just quickly answer these questions. So Annie, she has pain over her right forefoot, over the third and fourth toe, some burning pain, numbness, and tingling. What do we know this is? So we talked about this last week. We said that it was interdigital neuroma. That is most common in the third and fourth digits. Okay. Next one. So Amy, she has pain on the right forefoot. It doesn't tell us the age. She's wearing tight heel shoes. Second metatarsal head is widened, irregular, and flattened. Freiberg's. So clearly Freiberg's. And then the last one is we won't go through. So we'll stop it there. I can't really go through 33 questions. So next, and we'll still. So put your hands up if you'll come next week to YESPA. Yeah, so that will be our last session for fourth year. So I always think for fourth year. So I always think I'm going to finish on time, but it never happens. So It didn't happen much. It did happen. It happened like twice. Okay. So I apologize for taking so much time. Okay. Again, I just want to, just because I think about this a lot, and the fact that other people, they might go through like the black market Silk Road exams, and like I often feel like I can understand how you guys might think that's much more useful. But the reason I've been doing these faculty-release exams is because I want to help you to identify the style of questions that they ask, and to help you to revise, because I don't want you to know the answer. I want you to know how to get to the answer. That's more important to me. So I hope you'll forgive me for taking so much time with each of these sessions, but I hope it is good revision. I hope I see all of you next week. That will likely be our last session. I'm very thankful right now that I don't have to do Psych next week, because I wasn't looking forward to it. So I'm happy that we can continue on with this paper, but I'll see all of you guys then. My pleasure.
What about the week after the 29 exams?
Relax, okay?